Welcome. This is the Age Well Collective. I am Dr. Evan Osar. Today's topic is training rotation, and more specifically, corrective exercise strategies for helping you improve thoracic rotation as well as overall rotation in your older adult population. This webinar will feed directly upon the information you learned in last week's webinar with Robert Lenkel. One of the primary concepts I want you to take from this webinar is that there are things that hold your clients back from being able to express their rotation. And if you identify some of those common things that hold your clients back from being able to rotate, you'll be able to dramatically improve their posture, their balance, their walking, and essentially all the activities of everyday life. Because life is rotation. Whether you're playing a sport at a high level, like my team's quarterback, Russell Wilson, who at this time has 26 touchdowns already this season, playing at a high MVP level, or if you're doing activities of everyday life like our older clients are doing, whether they're gardening, because so many of our older clients want to be active and do things like gardening and picking things up off the floor or transferring heavy loads. That all requires rotation. And of course, walking and running is all about rotation. When you lose the ability to rotate, you will lose your balance. You will lose postural control. You will increase your risk of falling. So rotation is essential for life. So our goal, our objective, this webinar is to understand rotation. What exactly is rotation? And also, just as importantly, how to assess rotation and identify those strategies that limit and inhibit optimal rotation. And then finally, illustrate the integrative movement system corrective exercise strategy for improving rotation. So that way, when you leave this webinar, I'll give you specific strategies for one, assessing, two, addressing, and then finally progressing your clients through the functional rotation patterns that we choose in this webinar. Robert, I'm sure, gave you lots of exercises for rotation in last week's webinar. What I'm going to do is not necessarily reinvent the wheel, but just discuss some of the underlying components so that you understand what creates and promotes optimal rotation, and as well, what inhibits rotation, and then ultimately, what are the things that you can do very easily and institute directly into the programs that you're already using with success to improve rotation. One of the biggest keys and take homes from this webinar is I want you to really do the work on yourself. And I said really, I'll add two more reallys. Really do the work on yourself. So that way you can feel the changes in your own body. And don't ad lib, do exactly what I ask during this webinar. So that way you can see the changes that can be created when you help yourself and then ultimately your clients develop a more optimal strategy using the principles of the integrated movement system and understanding the components of rotation that we'll discuss here next. Thank you for joining me. Truly appreciate this opportunity. And there's gonna be a lot of great information. I'm gonna go very quickly in the beginning of the webinar so we can get to what you actually do about it. But there's a couple key components that we want to discuss initially so you understand why we do the corrective exercises that we do. Now, one of the easiest ways to visualize and conceptualize rotation is by looking at a bicycle tire, or any tire for that matter. If you think of the central axle or hub of the tire, where it sits on the axle, you can sort of think of rotation happening around that point, because that's essentially where rotation happens. And if you think about any joint in your body that rotates, this is essentially where it's happening. There's a central point in the joint or around the joint that rotation occurs. And rotation just happens in different planes of motion. There's rotation in the sagittal plane, there's rotation in the frontal plane, and there's rotation in the transverse plane. Now, in this webinar, we'll speak specifically about rotation in the transverse plane. But I want you to understand that all joints are rotating. They're just rotating through different planes of motion. So just think about this idea of a bicycle tire rotating around the axis of the tire. And When the tire is on optimally and is secured optimally, then the wheel rotates optimally. And rotation in the body is very similar and analogous to the bicycle tire. So there's three things we need. We need the optimal alignment. You need the optimal alignment of the tire itself, and you also need the optimal position and control of the axis of rotation. So we'll also look at the axis of rotation, and we'll also look at the myofascial control that maintains alignment and the axis of rotation. Now, a great way to conceptualize non-optimal alignment is just a bent bicycle tire. When you don't have great alignment of the bicycle tire, you're not going to go very far or very easily. Yeah, you could probably ride on a bent frame or rim of your bicycle tire, but it's going to be very awkward. It's not going to feel good. It's not going to be very efficient. And that's essentially what happens to us and our clients when we lose the ability to create and maintain that optimal rotation. And we'll discuss what that looks like here in a moment. Now, when we think about alignment, optimal alignment of the trunk and spine. So we'll focus on the trunk and spine mostly in this webinar, but remember, all our joints are rotating. Most of our joints, I should say, are rotating, just some more than others. But one of the key areas of rotation, obviously, is the trunk and spine. We need the right alignment because it places the joints in the best position for loading. And if you look at the two examples of these gentlemen here, Stephen to the left, both the gentlemen are in their mid-60s. Stephen just recently turned 64 years of age. He's an integrative movement specialist. He's the model I use for the majority of my books because he's able to maintain his alignment, and it's really a great illustration. I love the side-by-side comparison, and it's not to say anything bad about the gentleman to the right, but just one gentleman has focused upon his alignment, his breathing, his control, and one of these individuals has not, and it's very easy to see who has not, and why, I should say, why keeping up with your alignment, breathing, and control is so essential to posture and movement and longevity. Because Stephen feels good every day he wakes up, relatively speaking, he feels awesome. My patient doesn't feel as awesome as Stephen does. He doesn't move as awesome as Stephen does. He's not going to have the longevity, relatively speaking, barring some unforeseen accident, that Stephen's going to have. And this is really why I use these images, because this is something you can train and maintain. Now, can we help my patient get closer to where Stephen is? Absolutely. Will he ever achieve what Stephen does? Probably not, because he's not willing to put the work in that Stephen does. But again, it doesn't mean that we can't help my patient change or your clients change and improve their ability to rotate. So again, we want to respect posture and joint integrity. That's essentially what alignment is all about. It's the position, however, it's also the control that our clients need. So it's not just the client is in perfect position, it's also the ability to control that position. So what else enables optimal rotation? The second component that I mentioned was an axis of rotation. And again, very easy to see that if you put the bicycle on the axle, it's going to spin around that axle, barring the brakes being on or barring anything wrong with the axle being straight and the control around the axle being optimal. That tire will spin, and then again, you can ride your bike fast and furious if that's your goal. Now, when we think about the body and the spine, for example, we also have an axis of rotation. It's an imaginary line. You can visualize this as an imaginary line going down from the top of your head down through the center of the spine and out through the tailbone. Now, does not mean that this axis of rotation does not change. It just means that, relatively speaking, when we create rotation of the trunk and spine, we can visualize the trunk and spine, each vertebrae rotating upon this vertical axis, as you can see in the image to the left there. Now, this vertical axis is important because when the client is not maintaining their alignment, it's hard to maintain this axis of rotation. Then the client has to compensate. Similar to if the axle of on your car or your bicycle is off, then your tire won't rotate optimally. And that's oftentimes a cause of premature wear and tear on a tire, is when the alignment isn't good of the tires, or the axle is off, then you'll get uneven wear and tear. And it's just like that in our body. When we do not have optimal alignment and an optimal control of the axis of rotation, we're not going to get optimal rotation, and we will create premature wear and tear, which is often happens to our clients and many of us. And that's why we experience that degenerative joint process that we've discussed in previous webinars. Now, finally, you also need myofascial control, because in order to maintain the right alignment, the optimal alignment, and to be able to maintain the proper or optimal axis of rotation, you need the muscles that myofascial control. Now remember, the nervous system is telling the muscles what to do, but we have the myofascial control around the joints to maintain alignment and the axis of rotation, and then to create and control rotation. In the past webinars, we've discussed the deep and superficial myofascial systems. Now, we're sort of making this arbitrary sort of differentiation between the deep and superficial muscles, but they do function differently. There's different responses of the deep myofascial system and responsibilities of the deep myofascial system as there are with a superficial myofascial system. So we'll discuss those briefly. Now, the functions of your deep myofascial system. So this is sort of an illustration. If you think of the spine here being in the center, the rib cage being on top, the pelvis being underneath, you have the muscles that connect vertebrae to vertebrae to vertebrae, connect rib to rib to rib. These are the deep muscles that are underneath several layers of muscles right up against the joints. They function to connect joint to joint, just like this image is illustrating. They contract first. The reason why they contract first is they provide joint stability. And there's lots of research to demonstrate that the deep myofascial system, these deep muscles, contract prior to movement. Before you ever move your arm to go overhead, or before you ever take a step as you're walking, the deep myofascial system is contracting to stabilize the joint so that it provides joint stability, so then the bigger muscles that can then move you and do all the functional activities that you need to do. But you need that joint stability to provide that framework or that foundation for the motion that's about to occur. It also is the communication back to your central nervous system, the brain and spinal cord, about what's happening. And again, just another word for that is proprioception. The deep myofascial system has 3 to 7 times the proprioception that the superficial muscles have. So they're much better at communicating the position, the speed of motion, the rate of contraction, the amount of compression that's on the joint, the velocity of movement. So they're very important to the communication back to the central nervous system about what's happening with the space. And that's really what, when your clients come in, and many of our older clients, they have very poor proprioception, they're not getting the right signals back to their brain. So the brain is just doing, the central nervous system is just doing the best it can with the information it's receiving. That's why the training that I'll discuss here in this module, and you've heard me discuss in previous webinars, is so important. That's why we need to slow our clients down. That's why we need to be more specific about how we train movement. We can't just say to our clients, hey, just go out there and do something, just move, because they'll just move the way they've been moving. And that's with very suboptimal proprioceptive feedback to the central nervous system. It does mean that at some point we need to integrate the system, but initially, the benefit of corrective exercise or motor control training is to improve proprioceptive awareness of the body and space, and to communicate back to the central nervous system about the position, about the control, and about using the right amount of myofascial control to align and control the joints. We'll talk more about this as we go along. Now, we also need the superficial myofascial system. This does not mean, the previous conversation does not mean that we just need the deep muscles. We need these larger chains of muscles, like the anterior and posterior oblique chains, as you can see in these images from my book, Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. You see how these muscles cross the thoracolpelvic cylinder, the rib cage, and the pelvis, that core of the body. So from the front, you see the anterior oblique chain, and from the behind, you see the posterior oblique chain. These muscles connect the pelvis to the spine, to the rib cage. They fascially blend into muscles of the upper and lower extremity to connect the extremities through the core as well. So these muscles, these myofascial slings, are very important to rotation. However, remember, you need the deep myofascial system to set up that thoracolpelvic cylinder and to maintain that alignment, so that these longer chains of muscles, these superficial myofascial chains, can create produce the torque to create rotation, and ultimately reduce to control the amount of torque and rotation that's happening as well. So they function to stabilize. These are the big stabilizers of the body. So when you brace to do a squat or a deadlift or kettlebell swing, for example, these muscles have to be involved in stabilization. Your deep muscles are not enough. The deep muscles provide the joint to joint control, but they're not enough to control big movement and big need, or I should say a big requirement of stabilization, like a kettlebell swing or a heavy deadlift or lifting a child or lifting a heavy garden, you're shoveling dirt. You need that superficial myofascial system to help perform that activity. These are the muscles that provide that rotation. You can see how they're sort of connected across the midline of the body. When muscles and fascial chains connect across the midline of the body, they're very involved in rotation. So these two oblique chains are huge in creating and also controlling rotation. They're counter rotators, so that when you rotate your body to the left, for example, your trunk to the left, they have to stop you from over rotating to the left so that you can then rotate back to your right. So they rotate, but they also limit how far you're rotating. Think about your client that's a golfer. They swing that golf club or a tennis racket. When they swing, they have to decelerate that swing. So these muscles not only create rotation, but the opposite muscles, the opposite chains or slings of muscles have to counter rotate or decelerate that rotation. So the superficial myofascial system is responsible for those big movements of rotation and counter rotation. Now that we understand how basic rotation happens, why do we lose rotation? Because we all had great rotation at one point in our life. When we were small, we developed awesome rotation, and that's why you see, little kids, they're just all wiggly and jiggly because they have pure rotation. They have the ability to rotate in every plane of motion, through the sagittal plane, through the frontal plane, through the transverse plane, and through the oblique chains. I should say the oblique planes of motion. So we have the ability to use the joints, all the joints, to contribute to rotation. And then we develop suboptimal posture and movement habits. We stop exploring our environment. We stop being as dynamic. We start living more sedentary lifestyles. So we start to change posture and movement habits that ultimately changes soft tissue, like the myofascial system, like the ligamentous system, like all the connective tissue through the body. That ultimately, the more suboptimal habits that one has, that leads to the bony changes. And this is the degenerative joint process that we've discussed in previous webinars of how and why we develop so many issues as we get older. It's not genetics generally. It's the posture and movement habits that we've all created. Now, what caused us to have certain posture and movement habits? Well, we had posture habits that we just adopted based upon the things that we do in everyday life. So if you sat at a desk, you will assume a very similar posture to my patient there. However, we also have compensatory posture and movement habits, like the scar on my patient here. Many of us have had abdominal surgeries where they've maybe gone through, whether it be laparoscopic with 3 small dots, or maybe a traditional type of surgery like you see here, maybe for appendix or GI surgery, or C-sections, or other type of internal sort of procedures, even open heart surgery, for example. All these surgeries create compensatory habits because of pain. Anytime you have surgery, you're going to have pain. Some people have significant pain. You will compensate for that. Scar tissue. All surgeries create scar tissue. Some individuals develop more scar tissue than others. You've probably heard me talk about some of our patients that have come into our office after surgery. They've had strangulated bowels because the scar tissue from C-sections, from GI surgeries, have created bowel obstructions because of the scar tissue. We had a client that had a C-section, and she had scar tissue that was connecting her abdominal wall all the way back to her sacrum. So even though we can't see this scar tissue, it's happening, and many of our clients have developed compensations around internal scar tissue, and you can't see the scar tissue until you go in for a surgical reason. Like, for example, I just had a client that a couple of years ago, she had a ovarian cyst that she needed removed. She had her appendix removed when she was a child, 14 years of age. And the gentleman said, you have significant scar tissue within your abdominal region that I removed. But again, removing scar tissue just creates more scar tissue. But she had a chronic scoliosis, lower spine scoliosis, and a lot of that was likely due to the scar tissue formed from her appendix surgery when she was 14 years of age. And here she was at 67 by the time she had the ovarian cyst removed. So again, these surgeries that we don't think of or that we forget about, our clients forget about, oftentimes lead to compensatory posture and movement habits. And then we also have exercise habits. For those of us that do exercise on a regular basis, many of us are creating non-optimal or suboptimal posture and movement habits because of our exercise habits. And this is a very similar strategy that most of us have been taught when we're doing any kind of pulling exercises, rows, lat pull downs, or pull-ups. We are told to bring the chest up, squeeze the shoulder blades down and back, bring the body up out of thoracic kyphosis or excessive thoracic kyphosis. Unfortunately, these strategies lead to overcompression of the spine. They lead to hyperactivity of the lumbar erectors, the thoracolumbar erectors. This will oftentimes limit rotation because now the erectors that are spanning out across the ribs and the thoracic spine and connect down into the lumbar spine and pelvis, they become overactive and start to limit the amount of thoracic rotation. So many of us are training ourselves directly into loss of thoracic rotation. So these are just some of the habits, and many of our clients have multiple habits. They have the posture and sedentary lifestyle habits. They have the compensatory habits because of surgery, trauma, or injuries, and then they exercise and they feed right into these suboptimal habits. And that's why this is so awesome that you guys are part of the Age Well Collective, because we're sharing with you each week strategies to improve cognitive health with Ryan, balance and posture and movement with Chris, corrective exercise strategies to create more optimal habits with me, and then how to do resistance training to create more optimal habits around resistance training with Robert Linkle. That's why we love having you as part of our community and sharing this information with you, because there's so many clients that need your expertise and need this information. Now, one of the most common habits, and this is, I would put a big key next to this slide right here. If you're taking notes, hopefully you are. Write down one of the biggest habits, most common habits that leads to the decrease in thoracic mobility is breathing. This is a very common posture of someone who's not breathing well. They have the forward head, they have increased thoracic kyphosis, the rib cage is positioned behind the pelvis, or the pelvis is positioned in front of the thorax, and they have a distended abdomen, and they're predominantly a belly breather, just like my client is here, with chronic low back pain, balance issues, walking issues, and generally overall mobility issues. When your client says to me, I have chronic joint degeneration, I have chronic joint tightness or myofascial tightness, or I just feel tight everywhere, they have decreased rotation, what they're really telling you is, I am not breathing well. It's really hard to breathe optimally and maintain optimal breathing and lose rotation. You have to really try to lose rotation, and it almost never happens. If a client is breathing well, they generally have optimal thoracic rotation. This is a very common habit, and here's why it's not great to belly breathe. Belly breathing is not optimal breathing, because belly breathing generally occurs rapid and shallow. It overstretches and inhibits the abdominal wall, and it doesn't allow you to breathe, or I should say the client isn't breathing through their thorax, their rib cage, so they have lack of thoracic mobility. The lack of breathing into the thorax limits thoracic mobility, and then not breathing into the thorax perpetuates thoracic stiffness. So it just becomes a self-perpetuating cycle. You don't breathe into the rib cage, so then you lose mobility, and then the lack of mobility makes it harder to breathe into the rib cage. So now you become a belly breather, predominant belly breather, like my client before, and like my client here, Debbie, who is a predominant belly breather because she is like most of our clients. She also had a C-section when she was pregnant with her one and only child, and she has a compensation around the C-section scar as well, and she's developed hypomobility of her rib cage and spine because of non-optimal breathing, because of compensations from the C-section. She told me, she related a very interesting story to me after I described the situation to her. She's like, oh yeah, it's funny. I thought about what you said about the C-section. I remember that when I did my C-section, I went home with my child, My back was killing me. Just think about this. Get a brand new mom, just had a C-section, and most people when they have surgery, what? They rest, they recuperate, they go to therapy. But your reward of being a brand new mom with a C-section is you get to go home and take care of your child. So now you have the compensations around the C-section, around the pain, around the sleep deprivation, around the scar tissue. She's like, what I did is I learned how to pull my abs in and squeeze my butt because it took the pain away and allowed her to continue her life. Well, here she was. When I saw her 30 something years later, she was at the point where she needed bilateral joint replacements, her hip joint was replaced. She developed chronic neck issues and low back issues as a result. So this is why breathing relates directly to so many things. Past injuries, surgeries, and traumas relate to why so many of your clients are losing thoracic rotation and why breathing must be a part of your strategy to help improve thoracic mobility and hence thoracic rotation. So recap. Rotation is necessary for life. Everything we do in life requires rotation. I should say basically 95% of what we do in everyday life. Lying down, not so much. You can not be rotating. Sitting down, staring at the computer screen or a phone doesn't require a whole lot of rotation. However, any type of movement has a rotary component. We maintain rotation by aligning, by breathing, by controlling, using the right amount of myofascial control. We lose rotation secondary to common habits, sedentary lifestyle, surgery, trauma, injury, and compensation to that, suboptimal or non-optimal exercise performance, and then adding all these things together, not breathing well, will lead to the loss of thoracic rotation. So now that you understand the components of what create rotation and why so many of our clients are losing rotation, now let's go into what do we do about it and how do we help our clients develop and more importantly, maintain optimal alignment, breathing, and control so that they can rotate, so that they maintain more optimal posture, balance, and movement. The integrative movement system was a strategy for improving posture and movement so that we could help our clients do the things they need to, do the things they want to, and do the things, oftentimes return to the things they love to do. It's a very strategic process where you assess your client, where you address your client, and you help them progress. And one of the biggest changes in my career for the last few years, and especially the last year to 2 years, is now I'm 100% clear and 100% confident and have clarity in my process, the integrative movement system. So I'm going to share that process with you here. I've shared it with you in the past, but we'll look at thoracic rotation as through the lens of the integrative movement system. It's based upon 3 principles, the ABCs. When you align, when you breathe, when you control, you help give your client a more optimal strategy for posture and movement. And it's also based upon best practices, meaning we help integrate, I should say we use the best practices, we integrate the best practices from multiple fields, the myofascial field, the chiropractic field, the physical therapy field, the strength and conditioning field, the performance enhancement field, so that we take the best of what people are doing and bring it together. We're not trying to reinvent the wheel, so to speak. We're going to use what we know works. We're going to add in our components that we have found to work. And we're also going to, we're always going to put it through our assessment lens to make sure we're creating the changes we want, because we want to be as objective about our results as we can, understanding your assessments, how to perform an assessment and how to interpret an assessment is one of the keys to having best practices and being evidence-based in your approach, which is what you need and want to do if you want to truly be considered part of the medical profession, which many of you joined this Age Well Collective because you see the value in this. You see the value in helping people with their health, their overall health, and being a very important part, I would say almost the most important part, not the most important if a client has a disease process, but the most important for longevity. You're the health and fitness professional, just like you're the most important part because you see a client way more than any other professional when a client is not dealing with an acute disease where they need acute treatment. Longevity, you are the best solution for the individual. So phase one of the integrated movement system is the assessment. The assessment helps you identify your client's suboptimal habits. These are the habits that lead to and perpetuate chronic tightness, discomfort, or the inability of your client to perform at the level they need to and or want to. So when a client says to you, I just can't get down on the floor and get off the floor as easily as I used to, that's what they're telling you is like, I just can't perform it the way I used to perform. That is because of their suboptimal habits. Now, we've introduced you to the Age Well Collective assessment process, or the battery. Now, the couple assessments that I contributed to our overall assessment is posture, the overall alignment, as well as standing rotation, because that sort of looks at how well your client can full body rotate, how well their hips are rotating. We're going to get more specific about rotation and look more at trunk and spine rotation in this webinar. So our 3 assessments for this webinar: standing rotation, which you're familiar with, we'll review that. Seated rotation, which I'll introduce you to, what we're looking for and what optimal and suboptimal strategies look like. And then the half kneel rotation, which is really a cool way to look at overall the range of motion in the oblique, the anterior and posterior oblique chains. Now, standing rotation, you're familiar with this. It evaluates hip rotation. You keep your feet flat on the floor. You always stop in the center of rotation. Have your client stop in the center of rotation and rotate slowly. Compare side to side. Because yes, there are norms of ranges of motion, of hip range of motion, of spine range of motion. But unfortunately, we're using ranges based upon a very heterogeneous population. So you can't compare the rotation of a 20-year-old to the rotation of a 70-year-old. So one of the best ways to look at rotation, for example, or any range of motion, is to compare the individual to themselves. Compare left and right sides. The body does not like to deal with huge asymmetries in range of motion. So what we generally look for are less than 10 degrees of asymmetries. The body will always be relatively asymmetrical. What we don't want are huge differences in asymmetry, because these are the things that will cause the client or the individual to compensate. So first, let's look at my rotation, because you're going to do this. And like I said, I really want you to do these assessments and exercises on yourself so you feel the difference in your body, so that you can express to your clients the importance of this strategy and this process that I'm taking you through. So stand with the feet together, feet flat on the floor, rotate to one side and then rotate to the other. And you can see, like, yeah, big difference. That's much different than 10 degrees of rotation difference. So definitely decrease rotation to my left side. Do it one more time. Feels pretty good going to the right. Does not feel good going to the left. Now, here's what a lot of your clients will do. This is why you have to go slow. If you just go fast, it looks like I have full range of motion. And this is why a lot of your clients will say, yeah, it feels the same side to side, because they're going too fast. They're not stopping in the center. So let me play that one more time. Is they're going way too fast and they spin right through. You don't even see, now that you know that what to look for, you can see I'm compensating through my leg, that I'm not getting pure rotation. But you saw when I did it slowly, very obvious different side to side. That's why you have to do your assessments slowly. Have your clients do their assessments slowly as they're going through this process. Now, seated rotation is very similar, except now we're seated. So you want to have your client sit down with their feet about shoulder width apart. Make sure the feet are always in the same position pre and post assessment. Now we're looking more specifically at trunk rotation. So we're going to keep the feet flat on the floor about shoulder width apart. Again, same thing. Stop in the center and rotate slowly. Compare your client to themselves by comparing side to side. We'll cross the arms over the front of the shoulders. If the shoulders are too painful or they don't have good range of motion, they can always cross the shoulders. I should say, keep the shoulders down. And you notice I stay slow and stop in the middle. And again, you can see a pretty obvious difference side to side. So I rotate right, come back to center, rotate left. So not great thoracic rotation. You can even have a stick across the client's arms if they can hold a stick. And if they can't hold their arms up that high, then just keep them around the waist, that's fine. But just watch this trunk and spine. Don't watch the shoulders. Here's what a lot of your clients will do. You see the big difference again, not stopping in the middle and not staying on the axis. So let me play the beginning one more time so you can see you want to stay on that vertical axis. So if you look, visualize an imaginary line going through the top of my head and down through my spine. You see that I stay pretty much on that vertical axis. Now, I don't cue my client to do that. I'm just observing for that. I just know to do that so I can maintain a relative vertical axis and not compensate. Your clients won't know that, so they'll look a little bit more like this over here. They'll just do this sort of, you see, especially when I go to that left, you see how much I'm shifting off that vertical axis? That's what you'll start to see with your clients. And again, they could do it, they'll probably be doing it on both sides, but look for the side of greater compensation. Now, love this assessment here. Not every client can do it, but it's really an awesome assessment. The purpose is to evaluate trunk rotation. It winds up the oblique chains. You'll see by the position of my body as well as my arms, it will wind up the oblique chains. Now, the setup is very important, which is why it's not great for every client. You're going to keep the tibia of the front leg, that lower leg, vertical. The pelvis will stay level, which is why I'm going to elevate my knee. I'll show you what it looks like when my knee is not elevated. The arms are going to remain in front of the body and rotate slowly 3 times towards the forward leg. And again, you will compare side to side. So let me demonstrate one side, and then I'll demonstrate from behind in the next slide. So again, I keep the back leg vertical. I keep the front leg relatively vertical. It's a little bit forward, but you see it's relatively vertical. And I stay relatively well aligned, head over trunk over pelvis. My arms will come up in front of the body. Let me just stop that for a moment. Straight in front of the body with the palms up. The reason we go palms up and elbows straight is, again, it winds up those fascial connections between the shoulders and the myofascial chains of that trunk. The forward leg also winds up the posterior oblique chain by flexing that hip. So it flexes the hip, which stretches the glute and that posterior oblique chain. And we're also getting some stretching through the anterior oblique chain as well. That's why I love this assessment. But again, it's not for everybody. If you're struggling too much in this position, it's not worth doing the assessment. But if you can get your client into the assessment, and you probably can yourself, do this assessment because it'll be surprised at how different the range of motion is side to side. Now, when I rotate, I'm going to stay on that vertical axis, and the arms will stay in front of the body. So you'll not see me moving my arms past my body. So if you think of a straight line coming from your sternum, it goes straight down through the inside of your hands, my hands, and that way the arms do not leave the front of the body. That's how you know that you're rotating, relatively speaking, on a vertical axis. So do that 3 times towards the forward leg. So come back to center and then rotate. And again, you're comparing side to side, and then I'll do the other side. You're also comparing ease, because sometimes you'll say, hey, I don't really feel a difference. So then you say, what side just feels easier? One side will generally feel easier. For me, rotating to my right generally feels a little bit easier. The range didn't feel much different, but it just generally feels easier. Okay, now, what are some common compensations during the half kneel rotation? Again, I just want to show you this. When you do it from behind, the pelvis should stay level, which is why you have to elevate that back leg. Same thing with your half kneel chops. Anytime you do half kneel chopping, you got to elevate that back knee because most of your clients will not have their pelvis level. So you're compensating every single repetition. Because here's what it looks like if I do not elevate my back leg. And you already see I'm not level and I'm already rotated. I'm already compressed here through my low back. And then you'll also see another compensation. You'll see, again, pointing to the fact that I'm not level. And now when your client rotates, here's what they often do is they're extending and transitioning off that vertical axis. So again, don't over cue your client, kind of watch what they do, You knowing what you're looking for, you try to keep it real pure because you'll notice what you're doing or you'll notice the difference. Now, the last compensation right there, you see how I'm rotating my arms past my sternum. The arms should always remain straight and straight in front of the body the entire time, not bend, not move beyond the body. So again, this will be easy for you to do as a fitness professional. It's going to be a little more challenging for your clients. So you may need to cue them up just a little bit. Don't over cue them, just cue them as to how to perform the assessment because it's not an exercise, it's an assessment. So do not over cue them, just allow them to do the assessment so you can get some information. But again, if you're cueing them too much, then it's not a good assessment for your client. Okay, now you've done your assessments. Now it's time to move into your corrective exercises. That's phase 2 of the integrative movement system. This is where you develop optimal posture and movement habits. These are the habits that lead to and perpetuate improved range of motion. So when you have better posture and movement habits, you improve posture and movement and range of motion. You also give your client back the ability to perform at the level they need to and or want to. Not entirely, but it sets them up for success so that they can move towards performing at the level that they need to and or want to. So there's 3 parts of the corrective exercise strategy. First, you release, then you activate, then you educate. We're going to skip releasing because I want to show you the power of using corrective exercises without releasing. Because most people will do their releases and then do their other exercises and say, oh yeah, I feel great. But it must have been the releases and stretching. But I want to show you that you can increase range of motion without doing releases. Releases make it easier, but you can still create improvements without doing any releases by actually creating release by aligning, breathing, and controlling. You would want to release these muscles in many of your clients, glutes, external hip rotators, and hamstrings, because these are the muscles that will limit hip rotation. You will want to release external obliques, internal obliques, erector spinae, and latissimus dorsi for clients that have thoracic rotation issues. And again, you know how to do that, so I don't need to explain it to you. And I also want to show you the differences that you can create just by doing the activation patterns of the process. So why do you activate? Because once you've released, you have to upregulate or turn on the inhibited or underused muscles. This helps to improve joint alignment and control. And essentially, you're training motor control. You're training the brain to use the muscles in a different manner. Because if you just stretch, if you just use myofascial release, the brain doesn't know any other habit or pattern unless you teach it. So you release to create more optimal alignment and control and decompress the joint. You activate to teach the muscles, the motor system, the nervous system, what to do with this new range of motion and how to coactivate and how to create synergy between the deep and superficial myofascial systems. And then you educate your client. Education improves motor control, or how the central nervous system is controlling the muscles. It improves mindfulness and awareness. Education is also about the cues that you use and the homework you give your clients. So the cues that you give your clients and the homework help the education process. So we're educating throughout the session, and we're also educating through the homework, because this is where your clients start to own the information on their own. If your clients aren't doing homework, you're likely not with them. I should say, you aren't with them a long enough period of time to significantly improve them. You can improve them. They can get improvements with your sessions 2 to 3 times a week, but they're going to have much better results, much more sustainable results when they do the work on their own. That's their responsibility in the relationship. Now, we also have the principles of the integrated movement system that we all went through, we all used to develop optimal posture and movement. Align, breathe, and control, the ABCs of the integrated movement system. My niece illustrating this concept beautifully. When she's in the happy baby position, when she's in the modified plank, when she's in the split stance position, about to pull up, you see the beautiful alignment of her thoracopelvic cylinder. She's breathing 3-dimensionally. She has optimal control around her thoracopelvic cylinder, around her upper and lower extremities. So it's about alignment, aligning the joints in the right position for loading. It's about breathing to create the optimal position and control. The myofascial control that you need, the motor control you need to maintain this alignment, and then to align and move in the right manner, the ABCs. So we want to align the thoracolpelvic cylinder and use the most appropriate cues. A long spine, create space under the arms for people like me who are big shoulder grippers and pull down on the shoulders. Relax, let go, connect, visualize, imagine, think about. These are the cues that promote more optimal alignment for the majority of our clients. Squeezing, bracing, gripping are not great cues to promote more optimal alignment and proper motion. Those cues are appropriate for lifting sometimes, but they also increase myofascial compression. So we have to be careful and very strategic about the cues we use with our clients. So breathing, why is breathing so important? Because it regulates internal pressure. What keeps us upright is not just muscle control. It's about internal pressure regulation, just like blowing up a stability ball. It's the pressure inside the ball that allows a ball to remain stable and allow you to sit on it, lie on it, and not decompress or explode. Same thing with our body. It's the internal pressure that keeps us upright and doesn't force us or cause us to have to overuse the muscles to maintain upright position. It creates a myofascial link between the diaphragm, which is myofascially connected to the transversus abdominis, to the psoas, to the multifidi, and all the deep erectors of the spine. The psoas myofascially connects down to the pelvic floor. There also is a neurological link to all the deep stabilizers of the deep neck flexors, the tongue, the shoulders, the rotator cuff of the hip, the deep stabilizers of the foot. All these deep muscles of the myofascial system, the deep myofascial system, are all neurologically linked. So that when one of them turns on, relatively speaking, they all should turn on. Because remember, they're providing the stability for our body. So they allow our body to create that foundation, and then the superficial myofascial system can connect and create higher levels of stability and move us. So remember, belly breathing is not optimal breathing. It is not three-dimensional breathing. It is not using the diaphragm appropriately. It's actually using the diaphragm inappropriately or non-optimally and perpetuating suboptimal strategies in posture and movement and ultimately thoracic rotation. Now, breathing, again, we want to focus on three areas. The purpose of three-dimensional breathing as it relates to rotation is it mobilizes the trunk and spine, because when you breathe three-dimensionally, you breathe into the joints and expand those joints. It improves pressure regulation that allows you to suspend and be long and to maintain that alignment. It improves alignment and it perpetuates optimal alignment and mobility. So that way it's easier to maintain three-dimensional breathing. So essentially, here's what it looks like. Align the head and neck and thoracolpelvic cylinder. For many of your clients, you're going to need to put a pillow or a stack of towels underneath their head. Keep the eyes looking relatively up and relatively angled down towards your feet. Keep a little bit of a curve in the low back for some of your clients. Some of your clients will be in posterior pelvic tilt because of spinal stenosis. Do not force them into anterior pelvic tilt. First thing, you want to get the breath all the way down to the lower abdomen. So that way you know you have a good idea that they're going to be using their pelvic floor as they breathe. This is not belly breathing. If you notice, it's not just my belly expanding. I'm breathing all the way down to the lower abdomen. That's getting the breath all the way down towards the pelvic floor. Next, we want to breathe into the rib cage, side to side. So you see me put my hands on my rib cage, and then we want to take 3 breaths in. All our breaths are with the mouth closed, just breathing through the nose. Obviously now with masks, it's going to be a little more challenging to do this. So don't overbreathe your client when they're wearing the mask. Just teach them what to do. Make sure they go home and practice this. So now I'm breathing wide into my hands, but then my ribs are relaxing as I breathe out. So you'll see my ribs expand. And then as I breathe out, the ribs relax down towards the pelvis. And then finally, I'll breathe front to back. One of the easiest ways to breathe front to back is using a strap. So again, you can use the strap in the upright position, but I'm going to really have you focus on upper thorax because this is where your clients lose rotation. This is the number one key. Very few people are doing this to restore and also maintain thoracic rotation. But again, you can get your client breathing down low by putting a strap down low around their lower abdomen and breathe into the strap. So I just have the strap, a yoga strap, strapped and pulled across my abdomen gently. It's not pulled tight. I'm focusing on breathing down low. Then I'll bring the strap up to the lower rib cage to encourage breathing into the lower rib cage. Again, same thing, breathe into the strap, really focusing the client on breathing into the sides and back of the strap. Most of our clients are very poor posterior rib cage breathers. The strap is great because it gives them that kinesthetic feedback to expand into the yoga strap. A bathrobe tie also works well. You can also use an elastic, a piece of flat elastic tubing that will also work well for this as well. The great thing about the strap is it gives the client the kinesthetic feedback to send their breath into the rib cage wide and into their back. And then you want to put it up high above the chest, right underneath the shoulders, and send the breath into the strap. This is the area where most of our clients, if your clients have chronic shoulder and neck issues, they are not breathing into the upper back. This is what can dramatically restore thoracic rotation. Obviously, you would have done myofascial release first, but again, I want you to do this without myofascial release, without any mobility work, to show you how powerful breathing into the thorax can be. So breathing in and out through the nose, staying long through the spine, sending the breath into the strap. We do 3 sets of 5 breaths in the area that the client needs it the most. So as you're doing this on your own, just do 3 sets of 5 breaths in the upper rib cage where the strap is right here in this video. Now, we also need to teach your client how to control that thoracopelvic cylinder and maintain alignment. Control is all about utilizing the right muscles at the right time to successfully complete the task. So even though you're like, how does doing a quadruped or modified plank improve thoracic rotation? Because it improves the alignment and control of the thoracopelvic cylinder. It coordinates and integrates breathing with core activation, which is what our clients need to do when they're doing higher level patterns that we'll get to here shortly. It reinforces alignment of the thoracopelvic cylinder. It integrates breathing. So again, we start with the alignment, head and neck and thoracopelvic cylinder. I'm going to hinge forward, putting my hands upon the floor. You'll see me sort of wiggle my neck to make sure I'm not gripping my neck. And you'll see alignment of my head, neck, and thoracopelvic cylinder. So the first pattern is just doing quadruped weight shifts so that I'm mobilizing through my hips and maintaining alignment and control of the thoracopelvic cylinder. For a lot of our clients, that's a lot of work just right there, just getting them to align properly and shift through their hips and shoulders without changing thoracopelvic cylinder alignment. But without this ability, they're not going to be able to rotate appropriately. They will not rotate appropriately. The next pattern is to do an isometric hold. And again, the alignment I'm looking for is through the ear, shoulder, spine, and hip, maintaining this alignment and doing my 3-dimensional breathing. You'll see me shaking my head to make sure I'm not gripping my neck, because a lot of clients will develop neck issues in this position. So just keep checking the neck to make sure the neck stays relaxed. We love this position because it really starts to facilitate 3-dimensional breathing. Then the final progression is to go into the down dog position. So now we're starting to get length through the back of the hips, length underneath the arms. However, if you notice, still maintaining alignment of the head, neck, and thoracopelvic cylinder. And this end position here, right here, I'll pause this. You'll see the ear, shoulder, and hip aligned, and I'm still maintaining, to the best of my ability, three-dimensional breathing. Because again, we want to integrate breathing into thoracopelvic cylinder alignment. So that way, when the client gets to the upright position and we're starting to do chop and rotation type patterns, or those anti-rotation patterns that Robert discussed in last week's webinar, that they have the ability to maintain this alignment as the load and the challenge of the exercise starts to increase. Great way to develop the alignment, the breathing, and control. Now, you have to do your reassessments to see what change you created. Otherwise, you don't know. Did it actually change my client or did it not change my client? That's why we are sticklers about doing assessment, do an exercise, reassess. So this is my pre-rotation, this is my post-rotation. So without any myofascial release, no mobilization, just doing the exercise patterns I previously showed you, this is the difference in my thoracic rotation. So you see much improved. Again, I would improve even more if I did some myofascial release, but even without myofascial release, you see the change in my thoracic rotation. And you also see, without myofascial release, the change in my hip rotation just by aligning, breathing, and controlling. So now think about your client. If you've changed this, not only have you improved range of motion, you've improved the ability to use the muscles appropriately, rotate appropriately. You've changed this client's strategy. Now think about, I'm going to put resistance training, anti-rotation, or rotation patterns on top of this strategy. Now you've given them an opportunity for success. You're not reinforcing those old posture and movement habits. You've given them the ability to now take advantage of this improved range of motion and take it into those functional patterns to train and maintain rotation. So that moves us into phase 3. And Robert covered a lot of this in last week's webinar. However, I'll just sort of piggyback off what he did. So the purpose of phase 3 is to progress your client, to integrate the habits that you just created into the fundamental movement patterns. This helps your client to develop ownership of the optimal habits, and it supports the successful completion of one's functional goals. So this is really how you start to move your client towards achieving the things they need to, want to, and ultimately love to do. So we love chop patterns. We use mostly anti-rotation. The purpose is to develop TPC, thoracopelvic cylinder alignment and control. This is where we always start with our clients. We start them with anti-rotation patterns, because if you can't control rotation, then you can't produce rotation. So you have to teach your client first how to control it. We'll use a chop pattern first, because when your client can't rotate or doesn't rotate well, you can start the process just by doing a simple medicine ball chop pattern. So you see I maintain thoracopelvic cylinder alignment. You don't have to do it as fast as I'm doing it. But again, you see relative alignment of a thoracopelvic cylinder as I'm chopping through the shoulder and the hip. It's basically a hip hinge with medicine ball chop. Easy pattern to do with a dumbbell, kettlebell, and or medicine ball, maintaining alignment. Now the frontal plane chop is a little bit more challenging. It's still relatively an anti-rotation pattern because now you're controlling the momentum of the ball. The important thing through both these patterns is the maintaining alignment and control of the thoracopelvic cylinder. So even though it looks like I'm rotating, which I am, a lot of that rotation is happening around my hip joints, not around my spine. My TPC is staying relatively well aligned. You'll see that more from the backside here. You'll also see that my pelvis stays relatively level. The TPC stays aligned. So if you drew a straight line up through my spine, the spine is relatively vertical. The TPC is aligned. I'm transitioning and chopping the weight down mostly through my shoulders. However, the TPC remains aligned. So it's actually a challenging pattern to do well and not create flexion or extension or lateral bending and stay on that vertical axis. Now, we can add in anti-rotation with a resistance band. But again, it's still the same anti-rotation, mostly rotating around the hips. We can do this half kneeling and or standing. I'll show you the half kneeling version first. We're always controlling the TPC. You align the TPC first. We'll go into that half kneel position, again, to align that TPC and keep the pelvis level. And if you'll notice, my TPC does not rotate. I'm rotating around the forward hip. The whole TPC is rotating. The band is pulling me out of rotation. However, I should say the band is, the force of the band is pulling me out of rotation. I'm maintaining alignment as I'm rotating away from my forward leg. You can also rotate towards your forward leg. It's easy and easier initially to rotate away from the forward leg. Maintain the arms in front of the body. Again, it's the very same setup as during the assessment, but now we're actually adding that resistance. But you notice my arms don't move. The band is providing the resistance, and I rotate away from the forward leg, around that forward hip. The tibia stays relatively vertical. The lower leg stays vertical. I'm not moving the knee, so that way I'm moving, mostly rotating around the hip. Now you can also do this pattern standing. So this is the standing version of it, very similar, but now I'm just in a split stance position, or I should say I'm actually rotating around my hip in this version. Start with the same alignment. My upper body, the TPC, will remain controlled. And then I rotate around my left hip, but the upper body, the TPC, stays stationary. Love this pattern because it really teaches your client to own the TPC position through a transverse plane of motion. You'll see my hip, knee, ankle, and foot of that left leg stays stationary. I'll flip around. Now I'm going to rotate towards my right leg, maintaining alignment, that long spine. My hip, knee, ankle, and foot will remain aligned. My TPC remains aligned. My arms do not move beyond my body. So the band's trying to pull me out of this position. I'm maintaining this position. I'm rotating around the hip, my right hip, maintaining alignment of the TPC as I rotate, making sure my neck is not gripping. That's why I keep shaking my head, just to make sure I'm not gripping for my shoulders and or my neck. You notice I'm using a very light resistance. A lot of our clients will use resistance that's too heavy, so it's hard to maintain or impossible for them to maintain their alignment on that vertical axis. So use a light resistance, and even with our professional golfers that we train, this is still the same light resistance because we want them to create this pure axial rotation. Now, there is a point in time where you can train optimal rotation. When your client has succeeded in those previous patterns, you can train pure axial rotation. So this is the half kneeling position with trunk rotation. You rotate again on that vertical axis. The arms will be maintained in front of the body. You're going to begin with no resistance and then you can add in band resistance, but we love the Pilates ring or something like that. We'll often use a roller in front of the body. But again, we'll start with the same alignment. We'll go into the half kneel position, and you'll notice that I'll rotate away from the camera or towards the forward leg. Actually, I rotate both directions on this one. But you'll notice I keep the TPC aligned. The lower body doesn't move. And you'll see the wrinkles in my shirt. What's cool about the wrinkles in my shirt, especially as I turn this way, you'll see that oblique chain, the stretching of that oblique chain as I rotate towards the camera. But if you notice, I stay on that vertical axis. My arms do not leave the front side of my body. So now I'll do it from behind so you can see that I relatively stay on a vertical axis. I maintain my alignment of the TPC, head, neck, and rib cage remain aligned. Rotate on the axis. And that's why we keep the Pilates ring directly in front of the sternum. It does not rotate past the sternum. The center of the Pilates ring remain aligned with the center of the sternum. This makes for a great way to assess that your client is getting pure axial rotation or pure rotation on that vertical axis. And remember, when you're done with your rotations, check your range of motion, reassess. So programming, again, we do generally 10 to 15 minutes of corrective. You can have your client come in and do this work beforehand. Do your strength, balance, cognitive work, and then always give your client homework. Reassess, give them homework, give them something simple to work on. Breathing, simple trunk rotation with breathing, simple balance exercise, simple balance cognitive and maybe even a resistance exercise like a squat. Give them something to have them start to own their homework. It's not enough to have your client come into their session 1, 2, 3 times a week and hope that that's enough to undo all the things they're doing in everyday life. What's crazy about it is a lot of your clients will improve just coming in a few times a week. But the more advanced your clients' issues are, or the more significant, the more multiple levels of issues, the more surgeries, the more trauma, the more injuries, the more deconditioned your client is, the less optimal their breathing is, the less optimal their thoracic rotation, the more they need to do on their own. Don't take on your client's issues. I should say, don't take responsibility for the work your client is not doing. Educate them, empower them, and then make them responsible for their part in the relationship. Summary. We've discussed thoracic rotation and what stops your clients from rotating. It's oftentimes the habits they create through the course of their life, oftentimes secondary to sedentary lifestyle, secondary to surgeries, traumas, injuries, secondary to non-optimal exercise habits. That would be more you and I. Then we perpetuate these habits, especially these non-optimal breathing habits. We discussed the process, the integrated movement system. You assess your client to identify their suboptimal habits, the reason why they're getting tight, having discomfort, or can't perform at the levels they need to and or want to. We use the corrective exercise, our corrective exercise strategies, to help them create more optimal habits. These are the habits that your clients need to use to start to change motor control, to change these brain programs that ultimately they'll take into the fundamental patterns, the squatting, lunging, bending, rotating, pushing, pulling, gait, balance, and carry patterns, the cognitive dual tasking activities that our clients need to do. Finally, use the right progressions. Teach your clients how to breathe, how to maintain optimal alignment and control of the TPC. Train the anti-rotation patterns first, because if they can't control the anti-rotation, they're not going to be able to control rotation. Then progress your clients to rotating so that they learn how to rotate on the axis, and that's where you really start to get those magical changes, those dramatic changes, the significant changes in their posture, in their balance, in their walking. Because when you follow this process, even if you have your client assess their walking or their balance before and after what we just went through in this webinar, it will be improved in the beginning of the session and through to the end of the session when you have them reassess at the end of the session. That's why I want you to do the work from this webinar. Do it exactly as I described it on yourself without any myofascial reliefs. And then let me know, put it in the chat in the Facebook page. Let me know how it went. Do the work. Do it exactly as I explained it in this webinar. Let me know. When you add the myofascial release, it will be even more significant. Your changes will be even more significant. But I want you to really experience what it feels like in your body, so that way you can more confidently express the power of breathing, the power of optimal alignment, the power of these changes that we're creating through corrective exercise. And that's how you start to get buy-in for doing homework. So I want to thank you so much for tuning into this webinar. I had a blast sharing this information with you. Like I said, feel free to put questions in the AWC community Facebook page. I'll answer them. If I don't get back to you, just keep posting them. Let me know. I will answer your questions, and we'll come together at the Age Well Collective, where we all come together, and that's another opportunity for you to ask your questions and get them answered live. So thank you again for being part of our community. Thank you for all you do for your clients. Let's go empower our clients. Next up, my good buddy, Dr. Chris Thompson. He'll be up next week with his module on balance. Thank you so much, guys. Have a great day. This is Dr. Evan Osar with the Integrative Movement System and the Age Well Collective.